Hi there, it's Dr. Monica Agarwal bringing you another episode of Seeking Voices, exploring the science of health and healing. I have a really exciting and fantastic guest coming your way today. Her name is Dr. Gina Lundberg. Gina is someone I've known for some time now because she's a fellow cardiologist, but she's so much more. She's a professor of medicine at Emory University School of Medicine in the Division of Cardiology. She served as the clinical director of the Emory Women's Heart Center since it was founded in 2013. She's a preventive cardiologist like myself, but specializes in particular in heart disease in women, lipid abnormalities, and cardiovascular risk reduction. She founded the first women's heart prevention program in the state of Georgia in 1998. Dr. Lundberg's service at Emory University includes improving outcomes for women with cardiovascular disease, but also improving gender equity for women in cardiology and encouraging more women to choose cardiology for their careers. She attended medical school in Georgia, then went to Rush University for her cardiology fellowship in Chicago. She's the chair for the American College of Cardiology Women in Cardiology Leadership Council and also serves on the same council for the American Heart Association. She's a co-chair for the National Lipid Association's DE&I committee. She's a primary investigator for all sorts of trials. She serves as on multiple editorial boards for cardiology journals. She's a frequent reviewer of so many manuscripts. She's just really smart and cool and awesome. I have loved Gina for so long, ever since I met her. What I really wanted to tackle today when I talked to her was about the topic that is near and dear to my heart, mostly because as I get older, I'm interested in this topic, but so many of my patients are dealing with it, and that topic is menopause. So we're going to tackle menopause from a heart disease perspective today. When is hormone replacement therapy okay? When isn't it? When should we stop it? Why should we stop it? What are the right ways to use hormone replacement therapy? Are there alternative therapies? So these are exciting. This is going to be an exciting topic, an exciting episode, and stay tuned to hear some great information. So great to see you, Dr. Gina Lundberg. I'm so excited that you're here on the show. I have so many questions for you, and so many people have lots of questions and thoughts about this important topic of menopause. But before we get started, I wanted you to tell us a little bit about yourself. Who are you? Because, people see you as this professor of medicine at Emory University. I mean, how did you didn't start that way? I mean, tell us a little about yourself so people can get to know you.
Okay, well, I definitely did not start that way. In fact, I'm first generation college graduate, and no one in my family's ever been a physician. So that was all new territory for me. In fact, I never even considered being a physician until I got to college at University of Georgia. And the pre-med counselor reached out to me to find out why I was studying biology and what I was doing. So it really was this, uncharted path of, no one there to guide me. I went into internal medicine and really loved cardiology and wanted to go into it, but I'd seen very few female cardiologists. In fact, the first female cardiologist I ever met is Sheila Robinson, an African-American cardiologist who's just an outstanding interventionalist and mentor and role model. So that was part of it. Is all during my cardiology training, I was the only fellow in my year, and I only had one female mentor, and that was Dr. Annabelle Volgman, who I treasure that relationship, and we're still very close even now. I went into cardiology to, try to prevent heart disease, and I'm a preventive cardiologist. But what I noticed along my journey was that women were really being dismissed. They were sort of patted on the head and told, oh, that's probably stress or gastroenteritis, GERD, go home, have a bubble bath, a glass of wine, and you'll be fine. And what I found was women would present with chest pain and have symptoms, and no one even got an EKG. So in 1998, I started the first program specific to cardiovascular disease in women, the Women's Heart Center in the state of Georgia. And I carried on doing that. And around 2004, as you know, AHA started Go Red for Women, which really sort of endorsed this and increased the awareness. When I first told my colleagues I was going to start a women's heart program, they really thought it was crazy. And they said, oh, you'll take care of all the fluky palpitations and chest pain that in their mind wasn't even, angina. But women started to hear about me and started to come to me, and it became a very successful practice. And in 2012, I was running the Women's Heart Center at St. Joseph Hospital in Atlanta, Georgia. And Emory bought our hospital, and they came to me and asked me to come on board as their clinical director and replicate the process throughout the whole Emory system. And that was just a dream come true. I think I was always meant for academics, but it's surprising I spent 18 years in private practice before joining Emory. And I am a full professor of medicine, which is very rare in women. Also, when I became professor, I was only the third female in the Department of Cardiology of 130 cardiologists to be a professor. So my journey now is to continue to take better care of women through sex-specific medicine, and menopause is a huge part of a woman's life, and so this is a lot of what I do. But on my other hat, I'm the chair for the ACC Women in Cardiology Leadership Council and section, and so I'm really trying to get women to come into cardiology, consider it, and then stay in it, because we have too many physicians leaving, because a woman feels more comfortable talking to a woman. And there's actually great studies that show women spend a little more time with patients, on an average 2 minutes longer, listen a little more broadly, and take better care in many instances, particularly in the ER when you're trying to diagnose a heart attack. So I just want to see women get the best care they can get, and I want to see more women of color, lots of women of diverse backgrounds joining medicine, joining cardiology, so that my daughter and hopefully my grandchildren will have better care than the women received in the 80s, 90s, and unfortunately even still today.
That's beautiful, Gina. It's so nice to hear that story. I think, it's important for people to hear that, because I think people often women don't realize how much they are dismissed more than men. And, there's so much data about, diagnosis. Can you speak to that? Like, when women go to the ER, in terms of diagnosis, do they get diagnosed as fast, and sort of how their interventions and their outcomes go, because just by being a woman?
Yeah, well, unfortunately, when women go to the ER, they almost always use the word chest heaviness, chest tightness. In fact, they shy away from the word pain, and sometimes will say, "Now, I'm not having pain." And the ER doctor who's receptive will know that all kinds of symptoms can be angina, shortness of breath, increased fatigue, not being able to do an exercise or exertion that you did in the past, dizzy, lightheaded, passing out, syncope. These can all be manifestations of an acute coronary event, also chronic angina. And so you really need a physician who's taking a minute in the ER to listen to you. And then every woman needs an EKG, and every woman needs to have her troponins, the proper lab work to rule out a heart attack. And too often they are just sent home and told to follow up without these tests even being done. We have lots of in-hospital testing that can usually be done that day: exercise stress test, nuclear stress test, stress echo, CT angiogram. All of these things can be done to immediately rule out the heart attack. So, one, I think women need to advocate for themselves. If you feel like you're being sent home inappropriately, refuse. And two, make sure you're at least getting an EKG, that you're being listened to. Too often, I've seen a woman who was triaged to a lower level, kind of sat in the back of the ER, and they didn't even get an EKG for hours. And then they find she's having an ST elevation heart attack, a STEMI. And now
Which
they're
is
rushing her off
which is
to
an,
the
which is an emergency, right? Like, that's an emergency for those of us who don't know. That's an emergency where we want to get people into the lab within 90 minutes of arrival, and they've just been sitting there because nobody did an EKG.
Exactly. And then when they finally figure it out, everybody's rushing around frantically. It's chaotic. And some of these women have not only suffered injury that shouldn't have lasted that long, they've got sort of a post-traumatic stress disorder from this whole event where they were being ignored, and now everybody's in a panic. And so that's not good for them psychologically in the recovery. So it's a lot of things, but women's chest pain, women's symptoms don't always present like a man's, and we need to advocate for ourselves. And if you have risk factors, strong family history of heart disease, particularly if your mother or father had it before 65, you really have to advocate for yourself.
Yeah, I love that. I mean, it's so important. That this is a lot of my clinic, as well as where I see a lot of people come in, and often, sadly, they say, they've moved around from multiple cardiologists because they weren't being taken seriously. And I do appreciate that those women are advocating for themselves because they know something is wrong or just not quite right, and they want to be sure. Why is it that the men are being treated differently? And so, bravo on the work you're doing. I really want to get into the topic that I think people are very curious about. And certainly you've helped me, Gina, in cases before where I needed some guidance, input. What would you do kind of thing? So I appreciate you being here today to talk about this topic of menopause. So I thought maybe you could start by talking to us. What do we know about menopause and heart disease? Like, what happens to people when they hit menopause in terms of their heart disease risks, their blood pressure, their weight, their cholesterol? What can you speak to about that?
Well, the simple version is everything becomes unfavorable. If you had good cholesterol before, you're going to find your LDL is going up, the good cholesterol HDL is going down, the triglycerides are going up, the arteries are losing their elasticity and getting stiffer, so you're having higher blood pressures. The bottom number, the diastolic, tends to go up first. Women feel that they're gaining weight, their metabolism is definitely slowing down. In fact, sort of a rule of thumb is you got to cut back by 100 calories every decade after 30, and certainly after menopause. We're moving toward diabetes or insulin resistance, so our sugars aren't quite as good as they used to be. And we tend to store weight around our belly. That visceral fat tends to increase after menopause. Our arteries aren't as reactive. We tolerate heat less. I mean, there's just so many things. I tell women it's a head to toe process from, yes, your hair is graying, but it's also changing in texture. Your skin is changing. It's thinner. You bruise more easily. Your breasts start to sag. Everything. And so the things that really affect the heart are the changes in blood pressure, the changes in the blood sugar, the unfavorable lipids, and that we don't react as well. What the inside layer of the arteries is called the endothelium, and it should dilate when we exercise and we need more blood flow, and it should constrict when we're sleeping, relaxing, in a state of low heart rate. And that change doesn't happen as quickly and as appropriately as it did too. So there's a lot of changes, very physical changes, very biochemical changes in our bodies at menopause. And so that's why 10 years after menopause, and the average age in America is 51, every day 6,000 new women join the menopause club. And I've heard it said that we can all choose to have children, to get pregnant, but none of us is getting out of menopause. It's not something you choose. It happens. It's 100%. And we're all going to go through it at some point. And for some of us, it's quite miserable. A lot of vasomotor symptoms, a lot of genitourinary symptoms. And these are in addition to all the cardiovascular things that are getting worse. So it really is a rough time. The good news is, one, there's a lot that we know about it, so you can be proactive for your health. Healthy diet, exercise, things that you advocate for every day, they really make a difference in menopause. A good night's sleep becomes a very valuable thing. If you slept well before and you don't sleep well after, you realize what a blessing a good night's sleep is. But there are a lot of things we can do to improve it. And then, for 60, 70 years, we've had hormones, which we're going to talk about in detail, and if they're good and if they're bad, and how they might be helpful.
Yeah, no, that's great. So I love that explanation, and I don't know if I knew that statistic about 6,000 women per every day, and I think that's a good statistic to know and think about, because we're not alone, right? As we age, we're not alone. There's so many of us that are going to go through this process together, and sort of talking about it and bringing maybe the stigma around menopause, removing that, and sort of having these conversations. So you know that this is normal, or this weird thing that's happening to you is something that 6,000 or 5,999 other women are going through with you. And so I really like that.
Well, and I'd like to add to that, Monica. We did a session at ACC, the American College of Cardiology 25, earlier this year, with physicians going through menopause. And I'll to tell you, I'm 64 years old. I've been suffering with menopause and vasomotor symptoms for the last 13 years. But we did a panel with very well-known cardiologists. I won't say their names. But we talked about, as women, not just cardiologists, but how unprepared we were and how uneducated we were. In fact, one of the cardiologists shared that she was feeling tired, she was feeling terrible, she was having a hard time getting through the day, she really didn't even know what was going on. And she found out she was terribly anemic because during her early menopause, she was having heavy, heavy menstrual flow. And we really shared how, of course, the more layman woman doesn't even know these things. And here we have, cardiologist professors going through menopause as the patient and still being unprepared and uneducated for so much of what can happen during menopause. So I really want to assure your audience that if they feel unprepared and uneducated about this, you're not alone. And don't feel bad about it, because until it happens to you and you're an N of one, right? Everyone is their own research project of one. You don't know how it's going to affect you. And we've done studies. There are 85-year-old women still having vasomotor symptoms, hot flashes, poor night's sleep. And I pray I'm not one of those. I'm worried I am, because I still deal with it. But it's something that women don't know about. We don't talk about it enough. Sharing your experiences can be very important. And there may be things that you think, oh, that's just old age or whatever. Go to your gynecologist. There are gynecologists who specialize in menopause. There's a board certification in menopause, and get that extra help you need, because kind of our mothers and our grandmothers are like, oh, everybody did that and we didn't even talk about it. But women today do want to know more about it and want to know what's normal and what's not, and how can I feel better and how can I feel younger when I go through this. So I just wanted to throw that in. That
No, I think that's so important. I mean, I grew up in a family that you tough everything out and nobody talks about anything. And, when I got my menstrual period, I just figured it out. There was no one to sort of guide me along. And I am not interested in that world. And I want people to talk about their feelings. I want to talk about my feelings. And I'm okay being sort of not so tough cardiologist who talks about the fact that, this kind of sucks. And so I appreciate so much that you're bringing up so many important topics. Number one, we're not alone as women. We're all going to go through this process. So we all are just at different points in the spectrum. Number three, that everybody has a different symptom complex. And the only way we're going to know if it's okay or normal is if we talk about it. And then we have to take away that stigma or fear about it. Gina, you've been using a word called vasomotor symptoms. I thought maybe you could just define that for the audience.
Sure. Well, that's when our central nervous system kind of goes, freaks out, goes crazy. And it can feel like your heart's racing, and your heart rate literally can be higher, 100, 110, even 120. You feel hot, and it's this deep core hot. And you may break out in a sweat. You may have a drenching sweat. We call those women super soakers. Or you may just have a little light sweat around your face, your hair, between your breasts. Women will feel all kinds of brain fog to downright, I feel crazy, mood swings, irritability, being more aggressive, and then maybe being more docile, tearful, crying. Why are you crying? I don't know why I'm crying. Just these huge mood swings. And these are part of the vasomotor symptoms. They come from the central nervous system. The other end of our body has its own symptoms called genitourinary symptoms. And that can be, I'm going to the bathroom all the time. It burns when I go to the bathroom. It hurts when I have sex. I have dry vagina. The skin around my labia is not responding. I can't have orgasms anymore. My clitoris is super sensitive, or it's not responding at all. I'm not having orgasms anymore. All of these symptoms are coming from menopause and the change in estrogen in our brain and our other organs, but also in our urethra, our clitoris, our labia, our vagina. All of that area is very sensitive to estrogen. And as it loses the estrogen, and particularly if it's a very rapid decline, you get more of these symptoms. A lot of the vasomotor symptoms start way before you've even had your last period. So let me add the definition of menopause. When you've hit menopause, it's you've had 12 consecutive months of no menstruation. And you could go 11 months, and then if you have a period, that time clock starts all over again. So there's a lot of women who've had very few periods in their last year or two prior to the actual menopause. And premenopause can start in your mid 40s. If you go through full menopause before 40, that's called premature menopause. And if it's between 40 and 45, we call that early menopause. And that's a whole different situation. If you don't mind if I talk about that a second, Monica.
Yeah, please. No, I love this.
Well, that's just like when your thyroid poops out. What do we do if your thyroid, which is here in your neck, starts to decline? We give you thyroid replacement. Same thing, if your ovaries poop out before the average age of natural menopause, which I said is around 51, 52, it's changing, it's getting a little older in this country, then you have to be replaced. So hormone replacement therapy is not the same thing as menopause hormone therapy. Hormone replacement is essential. You will lose tons of bone density those first 5 years, and your actual risk of heart disease goes up if you've gone through premature or early menopause. So we want all of those women to feel safe and comfortable getting hormone replacement. There are a few women in that age category who've already suffered a heart attack or have stents or have significant cerebrovascular disease. Maybe they've had a TIA, a stroke, a heart attack. Particularly like a SCAD event, spontaneous coronary artery dissection, which can happen during pregnancy, but also happens occasionally with intense exertion or stress. All of those women we have to look at very, very, very specifically. But I'm talking about the average woman who's pretty healthy, who's had early menopause. She definitely needs hormone replacement to maintain bone and heart health. And then as she gets closer to 51, then she and her gynecologist should work out a plan to start to decrease those hormones just like they would happen naturally. So we're not talking about hormone replacement therapy today. Those women should take their hormones, stay on board with that, keep healthy.
So that's great, Gina. I want to just say that one more time. So if you go into menopause sort of before what the time we expect you to go into menopause, which is that 51, 52-year-old range, then we really want to think about hormone replacement. We're not calling that. We want to give people hormone supplementation. So those are a different group of people than people who are going through menopause at the normal age of sort of 51, 52, and where we were talking about quote unquote hormone replacement. I just want to make sure that people understand that we want you to take hormones until you sort of get to the natural, or what we expect to be the natural time of menopause.
Yes, absolutely. So that's called hormone replacement therapy. And what we're talking about today is menopause hormone therapy, MHT versus HRT.
Yes, thank you.
And we use all those acronyms, and it gets confusing for our patients and sometimes even for us. But yeah, so if you have early menopause, you want to take the hormones. So getting back to menopause is when you've gone a full 12 months with no menses, and then you can say that's the time of menopause. Some women may have a little bleeding after that, but it's really quite rare. And so at that point, you want to have definitely a talk with your primary care physician about what are my cardiovascular risk factors. And I'm talking beyond just what's your cholesterol, what's your blood pressure, what's your blood sugar, smoking, the typical things. We now know that rheumatologic disorders are increased risk for cardiovascular disease. You know that with your history of rheumatoid arthritis, but it's also lupus and psoriatic arthritis. And probably very soon adding to that list will be Crohn's disease and maybe even ulcerative colitis, these chronic inflammatory illnesses. We need to talk about, when did you start your period? If you had really early menses, that can be a risk factor. Did you have complications during your pregnancies? Did you have preeclampsia, eclampsia, gestational hypertension, gestational diabetes? Did you have preterm labor? Was your baby delivered before 36 weeks? Did you have a low birth weight baby? All of these things are indicative of future risk for heart disease. We're learning that chronic anemia is associated with heart problems. So there's a lot of these other risk factors that we don't even think of as being cardiovascular risk factors, but they are. And it's important to look at those and add those into your overall risk profile. One of the problems with like the pooled cohort equation, or even some of the newer equations prevent that sort of calculate your risk, they're really focused on a 10-year risk. And pretty much every 40 and 50-year-old woman has a very low chance of a heart attack in the next 10 years. But what we're really talking about is, what is your lifetime risk? Okay. Do you want to have a heart attack when you're 70, 75, 80? Of course not. So we're talking about like a long-term prevention strategy. And I heard the analogy of, it's like, when do you want to start your savings for retirement? We all know if we don't start saving for retirement till we're 50, you're not going to have much built up. But if you start saving for retirement in your 30s, you have a lot more built up. So prevention, you want to start that early. You definitely want to be preventive minded in your 20s and 30s, but by 40, it should be like a major part of your health plan and your health goals. I'm going to maintain my weight. I'm going to exercise. I'm going to eat healthy. I'm going to be more plant-based. I'm going to check my blood pressure more than that once a year at the doctor's office. Knowing your cholesterol, those things, really, that prevention strategy starts early. So when we sit down and do this risk assessment around the time of menopause, hopefully the woman's already implemented a lot of this, but this is also that time to say, okay, we got to get more serious. Some women still have all that baby weight on them, and we got to get that off. And so there's just a lot more that can be done. And then at that point, you can determine how safe are hormones. If she's having a lot of symptoms that indicate she needs menopause hormone therapy, or is she doing okay without it? There are some women who really have very few symptoms during menopause and feel good, and they have good bone health, and so they carry on without using hormones.
So, so many great things that you said in there. And I want to highlight one thing in particular, is that, we should be starting with prevention techniques in our 20s, 30s, and 40s, right? There's never too early, but it's that you're actually improving your cardiovascular risk, so reducing your risk of a heart event, but you're also reducing your menopausal symptoms, right? If you work on those. Can you speak to that a little bit, about how those same preventative techniques can also impact your menopausal symptoms?
Well, a lot of women get a lot of menopause relief by having a healthy exercise routine, by eating, lower fat foods, by having protein and lots of fruits and vegetables. Those things really do make a difference. Getting a good night's sleep, maybe turning off the phone or the iPad and those things, and having a good sleep routine. A good night's sleep makes the whole difference in how your next day is going to be. And checking on these lipids. Some women's cholesterol really jumps at menopause, and they'll say, I always have really good cholesterol, and now my HDL is plummeting, my LDL is going up. And we have a lot of statins and non-statins for implementing therapy if it reaches those levels. But a healthy lifestyle is really important. When you are a normal body weight, you have a lot less hot flashes, vasomotor symptoms than when a woman is overweight. And if a woman's in the obese category, which I tell women, it's really easy to be obese right now. It's 30 pounds overweight, and then you're in that O zone that we hate to tell patients they're in. By losing body weight, you have less hot flashes as well. So it's really important. We've got these great new drugs, the GLP-1 agonists, that are helping women. If your BMI is over 30, most doctors are comfortable prescribing them when they're followed appropriately and used appropriately. They're very safe and really have a lot of cardiovascular benefits, not just weight loss. They lower sugar, they have cardiovascular risk reduction, and they seem to be having some kidney benefits as well. So really new, exciting time that we have these very safe, effective drugs. I wish we had never called them weight loss drugs, because I think of them now as more like cardiac prevention drugs, the same way I think of statins. But unfortunately, they've had a lot of bad press, and the insurances don't want to pay for them because we call them weight loss drugs. I wish we hadn't done that.
Yes, no, it's such an important point. I think all of these are such great points, but there's so many women that say they're working on their lifestyle. They didn't maybe start in their 30s and 40s, but they're in their 50s and they're eager to improve things. They just find often that the weight doesn't come off as easily. And many people the symptom that they describe that they hate the most is this anxiety feeling that they get and the brain fog. And that's often the symptoms that I hear a lot of that people are eager to start hormone replacement therapy for. I'm sorry, menopausal hormone therapy. I like that you're corrected me on that. And so, what is the deal with these therapies? I mean, is it safe to use? Remember, I mean, maybe you can remind the audience also about, first we said hormones were okay, then we said they weren't okay. Now we've come somewhere in the middle. Like, what are these doctors doing? And when is it safe and when is it not? And so, like, how do patients feel okay with getting on therapy?
Okay. And this is a real, kind of black mark on the medical world. So I told you I started the first women's heart center in the state of Georgia in 1998. And I still take care of women who said, I remember, Dr. Lundberg, when you told me hormones were good for my heart, they were like the fountain of youth, and you totally endorsed hormones. And I did, as most OBGYNs and many physicians who dealt with women's health.
Right. But then just to be clear, you were just following the data.
Right. But it was observational data. And I think that's the key to your listener is we have different levels of how stringent the research is, how strong the data is. And an observational study is just, watching people who are on a drug. And so they've also generally wanted to be on the drug, and they tend to have a healthier lifestyle because they're more focused on their health. So you're really pre-selecting generally a better educated. This was a predominantly white women, educated, affluent, had money, had, good health care, and wanted to be health-minded, doing the right thing. So a lot of these observational studies really just showed us what, a healthy lifestyle and good education and being affluent would do for your health, which we know you get better health with all of those things. But the observational data said hormones were giving us better bone density. The studies looked like there were fewer heart attacks, fewer deaths from heart disease, and fewer all-cause mortality. I mean, all of it looked very promising. And then we did the study called HERS, HERS, which looked at women who'd already had heart disease and they were on hormone therapy. And we expected that they were going to be doing great, but unfortunately we saw more cardiovascular complications and deaths. And that was really our first big study, landmark study that said, hey, maybe this isn't as good as we think. And that came out in 1995. So we were already starting to question things. We had the large nurses' health study, and it seemed to look like hormones were great, but these were nurses. They were educated, they were working, they had money, they had insurance. And so again, it was an observational study. The Women's Health Initiative came out. The first data was released in 2003. I'll never forget that day. And they came out and said, women who are on hormones, and this was Premarin and Prempro, so conjugated equine estrogen, which isn't used much anymore, had more strokes, more heart attacks, but they had, and more breast cancer and more blood clots, what we call venous thromboembolism, but they had less colorectal cancer and better bones, fewer hip fractures. Well, the whole world came to a stop. All the news media's, reporting all this with a fraction of the information and not a lot of details. And women just stopped their hormones that day. I mean, it was like a worldwide national stop your hormone day. And within a few days, a few weeks, women were miserable. They were agitated. They were angry. They were having palpitations. It was just awful. And what, of course, all these women really needed was medically guided, maybe decrease in some of their hormones. And at the time, it was oral, and they were very high doses in general. So then we kind of, the pendulum swings. So we were over here. We all love hormones. Take your hormones. Hormones are good. But women who didn't even have symptoms were on hormones. Yeah. And then it swung the other way. Nobody gets hormones ever, never, never done. And the number of prescriptions written for hormones plummeted in the United States, and companies went out of business. Then we kind of, you know how then the pendulum finally comes back to the middle. We started to look at things and say, okay, is this a no for everybody, or what about some people? And what did we find in the observation studies that we didn't pan out in the what we call, randomized control, placebo controlled studies. And that's what Women's Health Initiative was. And so what emerged was this thing called the timing hypothesis. And what we hypothesize is the younger women, the women under 60 on hormones, seem to do better. And the women over 65, and in this study, the average age was 65, tended to do worse. And so we started to think maybe if you're closer to 51, the average age of menopause, hormones were beneficial. And if you're 85, way past, natural menopause, maybe you didn't need to be on hormones at all, or you just needed a smidgen, as we say in the South. So we started to do more studies. A large one was ELITE, E-L-I-T. Another one was KEEPS, K-E-E-P-S. And they started to really prove evidence that this timing hypothesis was actually very, very important. And then we also started to come up with new methods of hormone delivery, predominantly the transdermal patches, the creams, the vaginal suppositories, and we got into lower doses. The patch used to be 0.1 for everybody, which is maybe the dose you need when you're younger and close to menopause, but we now have a 0.05, a 0.0375, a 0.025. And so we have a lot more options for treating these women. And multiple studies have shown that the oral version, which has to be metabolized in the liver, can raise your triglycerides. We don't like that. Can raise your blood pressure. We don't like that. And so the transdermal patch, you're absorbing directly the estradiol that you need. It's not being metabolized in the liver. And so that's a lot safer. And then always, if you have an intact uterus, you need a progestin. Most people are on prometrium, 100, 200 milligrams a day, in addition to their transdermal patch, which there are some that last a week and some have to be changed twice a week. But there's lots of options there. And then there's combinations that even include a little testosterone, or there's testosterone gel that some women feel like they need. When it comes to recommending the hormone replacement, I think as a cardiologist, we just need to say transdermal, low dose, and a low duration of time is what we think is the safest. And then let the patient and her gynecologist go through the details of which patch she'll use, or which gel or cream, and how she's going to do that. I don't think the cardiologist should be recommending the exact medication. But I think we should be giving the guidelines of, we prefer transdermal. And then this duration seems to be a big thing too. Women who stayed on hormones more than 5 years have more complications. If you've stayed on them 10 years, you have more, and the older you are. So I think what's really relative is in a young woman who has symptoms, vasomotor, genitourinary, whatever, so a reason to treat. We need to look at her cardiovascular profile, but she can probably be treated with safe, effective patch and or progestin. And when we have, the woman over 65, certainly the 70, 75, 80-year-old, we need to be more hesitant about the hormones, but figure out what is it we're trying to fix.
So, I guess I love that you're saying that it's okay for us to use transdermal estrogen therapy with a little bit of progesterone, of course, if you have a uterus, and that there's a space for that for many women. How are we making the decision about who can, or who it's appropriate for and who it's not? And then how long is the right amount of time? And then before you answer that, I'll bring up that I do a lot of calcium scoring, as I'm sure you do in your clinic, which is to assess if people have sort of aged plaque in their heart, and it helps us risk stratify patients. And there are patients that are coming in that 50 to 60 range where they really want hormone replacement therapy, and they may have a calcium score of 50. And what are you doing with those patients? So to recap, the questions were, how long should they be on it, and how are we selecting patients maybe to start?
So in general, the rule of thumb that's being followed by American Heart, people who do women and heart disease, as well as ACOG, the American College of Obstetrics and Gynecology, is that the 4 symptoms have a reason, not just like it's not a vitamin that we should all take. So have a symptom that you're treating, an indication that you're using it for. Use the lowest dose necessary to improve that symptom or whatever it is you're treating, whether it's bone health, genitourinary health, vasomotor symptoms, and then the shortest duration. And pretty much every society, whether it's the 3 endocrine societies, the Menopause Society, ACOG, or the cardiology societies, agrees that less than 5 years is probably the safest. Over 10 years is getting more concerning. And again, these women in their 80s that are still on hormones, particularly oral hormones, that really scares me. Their risk not only of breast cancer is very high, but of thromboembolism, blood clots. And I usually see it in these women who are on hormones late in life, after they fall and break their hip, after they've been laid up in the bed with, pneumonia or something, or after a long car ride, and sometimes not that long, sometimes just 4 or 5 hours. So a long airplane ride, so it's associated with immobility. So, I think it's very concerning. The Endocrine Society pretty much sticks to, if you need it for bone health, we have other options, but yes, hormones are good for your bones. ACOG and the Menopause Society speak a lot more to the symptoms and symptom relief and, shared decision making and making informed decisions. And then in cardiology, we've been a no, and it's still, none of those medical societies says hormones are going to improve your risk of cardiovascular disease. Nobody is saying that, but they are talking about bone health and genitourinary health. And I think none of us would still say hormones are good for your heart. But the thing is there any harm? And so what is the Hippocratic Oath? First, do no harm. And if we're doing no harm and our patient feels better, I think the door is open to that. I certainly think that we shouldn't be saying as cardiologists that all hormones are a big no and forget about it. I don't think that's good patient care either. And it's certainly not personalized care, and it certainly doesn't involve shared decision making. Here's my problem with the calcium score is too many women are getting the calcium score before age 40. And if it's 0, it should be 0. We're on track.
Should be 0. Right.
Yeah. Now, when it's not 0, if it's even a 1 and you're under 50, you're going to be in the 90th percentile. And what that means is you laid down plaque probably a decade ago, and it's been there long enough to calcify, and it's going to continue to calcify. And while your 10-year risk isn't high, your lifetime risk is high, probably 40, 50%. The calcium score gives us this false sense of security when it's 0, but we're talking about young women, so they should be 0. And then if it's, say 50, well, that woman is clearly high risk, but her 10-year risk is still low. And she may be, really needing some hormones now just to get through maybe 2 or 3 years. And we're not talking about lifetime use. So that's when you really have to sit down. And I have a gynecologist I work with very closely at the Emory Women's Heart Center. She's a professor of obstetrics and gynecology, and she is a menopause specialist. She's taken the menopause board. And that's the ideal situation, right? You've got your cardiologist and your gynecologist who both know a lot about menopause and heart disease and hormones, working this out for you. But not every woman's going to have access to that. So again, you want to make sure you're on the lowest dose in the transdermal. And a lot of women think they're on the lowest dose. And then I'm like, no, there's 2 doses even lower than you're on. So you got to check that with your pharmacist probably. But if a woman has a high calcium score, that's when I really hit on the other traditional risk factors and the inflammatory risk factors. And I try to get her to, I say, how close to vegan can you get? And how are you willing to take a statin? And are you willing to do these things? And, aspirin's a little controversial in this, but we're not talking about primary prevention. We are talking about a woman with a high calcium score for her years. One other caveat, I have women in my clinic who have a 0 calcium score and they have severe peripheral artery disease or above the neck cerebrovascular disease.
Important point.
We have to realize that the coronary artery calcification is just one part of the whole cardiovascular system. And sometimes serious peripheral artery disease skips the heart, about 25% crossover there. But not everyone with peripheral artery disease, and I see a lot of aortic disease, has coronary disease. And so just because the CAC is 0 does not mean you are low risk. I want to know your LDL is low and your CRP is low and your hemoglobin A1C is low and all the other things. We can't just say that the CAC of 0 means you're low risk head to toe for life. That's not true either. We try to simplify things too often, and it's not. It's nuanced. It's personal. And so just having a CAC of 0 doesn't, particularly in other situations. Like I've got FH patients, their LDL is 220 and their CAC is still 0 at 50. But that woman is not only high risk for life for cardiovascular disease, she's got to be concerned about fatty liver and brain health and other things. So again, you can't just pick one test and say, this says I'm low risk. Give me my hormones. It requires sitting down with a patient and a thorough evaluation of the chart, and then what are her goals, and what does she want to feel better, and where does she want her cardiac health to be in her 70s and 80s.
So such important points. So as I think about it, and what I want people to take away is that hormone replacement therapy isn't a no, but it's also not like an automatic yes. And so that everybody, like if you have a symptom that bothers you, then certainly we don't want to just ignore that. But trying sort of preventive techniques and activity and exercise and using those sort of other techniques is really important. And then if you're still having a lot of symptoms, then we should think about menopausal hormone therapy. But what does that look like for each person? And really you're saying the shorter amount of time that you're on it is the better. And certainly sort of under 5 years is the ideal, because I have many patients that they don't want to come off, right? I mean, they like the way they feel on it and they don't want to come off, but we need to sort of always, when we start it, we need to have that conversation with people that there's got to be an endpoint. And then it sounds like in those patients in the middle with some heart disease risk, maybe an abnormal calcium score, maybe some peripheral disease, we need to sort of have a nuanced conversation with them to say, okay, well, you are at elevated risk because of these things. If you start hormone replacement therapy, to get through some of these symptoms, it really should be for quite a short term. Does that sound about right?
That's absolutely right. The one place that I'm an absolute no is in a woman who's had an acute coronary syndrome, stent or bypass in the last year. She really shouldn't take any. And it can be quite miserable. We tend to use the drugs that affect serotonin. The OBGYNs love Effexor and Zoloft. I like citalopram and escitalopram. There's a lot of good ones out there, but she really should not take it. In the same way, a woman who's had breast cancer should not take hormones. And that is the only absolute no. And we can do other things to help with some of the vasomotor symptoms. There's a new drug out for that. Also, we can do things for the genitourinary health. And I would allow Premarin estrogen cream, just the vaginal cream. There's very low systemic absorption with that. We do want her to have a nice, healthy sex life. There is sex after menopause, and so we don't want to affect that. But, if she's had elevated troponin, an acute coronary syndrome, recent stent, bypass, that's my absolute no-no.
But you would consider it in patients who had bypass or stents 5 years ago or 2 years ago?
Yeah, the farther away we are from the event and the more we've done to correct the risk factor. Let's say, you've got that ideal patient and she's went to cardiac rehab and she's lost 30 pounds and her LDL is 55 and her hemoglobin A1C is, 4.8, and she's exercising and she, following up with you routinely, and she's on good guideline directed medical therapy. So I'm thinking she's on an aspirin, she's on a statin, she's probably on an ARB, maybe a beta blocker, I don't know, but she's on good therapy, protective, preventive therapy. I'm much more inclined to let her have the 0.025 patch, maybe even if she's still in her 50s, the 0.0375 patch. But it also depends on her and her commitment to her health. And have we rectified a lot of these problems? And is she having good follow up with me? And I know she'll contact me if there's recurrent chest pain or anything like that. I'm much more comfortable with that. But unfortunately, having a bypass or having a heart attack isn't always the most motivating thing. And some patients haven't changed these risk factors or improved their lifestyle yet. And in that person, I'd still be very hesitant.
Gina, fantastic conversation. I thought maybe we would end this conversation with, you brought up some other alternatives. So I'd love to sort of do like a little round out to say, we talked a lot about prevention, a lot about movement and how those are impactful. We've talked about the hormone replacement and the nuance there. If we round out this conversation about supplements, you brought up antidepressants and 2 in particular that you like or your gynecologist like to help with some of the symptoms of menopause. What other, do you believe in any supplements for menopause that are beneficial? What do you think about that?
Well, the Menopause Society has put out a nice guideline for patients. It's on their website of the non-hormonal alternatives for menopause. And, I've had individual women who come back and say, like, people talk about black cohosh, that really helped them. But I've had other women say, didn't do a thing for me. I've had women who just getting a routine exercise every day has really helped. So it's also very individualized. I think that a healthy diet, I'm a vegetarian. Once you go vegetarian, you think the whole world should. But I did it at 55 and I found that it helped me lose weight. It brought my LDL cholesterol down another 18 points without any medication changes. And I felt like I slept better. And I didn't have near as many indigestion type symptoms at night, burping, reflux. So I think it's, ideal. You have to be careful with your protein and your B12 and things, but I think it's a great alternative to think about as you get older. But healthy lifestyle makes a big difference. For some women, they like taking a little extra magnesium. We don't have large studies that show that these things help, but I've had very many individual women who thought it helped.
Yeah.
So there are supplements, and again, a low dose of hormones is fine to try, but also it doesn't kick in, like you're not going to feel better tomorrow. You have to have been on the therapy probably for several weeks before you notice it. And so sometimes it's hard to know what is really helping when women start doing all of it at once. They change their lifestyle, they lose some weight, they maybe start taking some supplements. And so then it's hard to know what's what. But I really think that there's a lot of resources out there. So it used to be called the North American Menopause Society. Now it's just called the Menopause Society. They have great information for patients. Also, the Society of Women's Health has a whole area on their website for menopause symptoms. And it's not just our patients who are going through this, but as we have an aging population of physicians, we're going through it too. And I think it makes us more interested and more compassionate and a little more sympathetic about how disruptive this is. There's been a lot of talk lately about menopause in the workplace and having a fan, having maybe changes in what you can wear at work. Maybe if you can have layers and take them off. If you have a break room, you can go cool down in. A lot of these things are coming to the forefront, and they weren't 10 years ago. And so it's good to see this happening.
Yeah, I think that those are great points. I think, and again, more conversation, more honesty, being sort of, when I, I had 3 miscarriages before I had my 3 kids. And for years, I couldn't even talk about it partly because it was so emotional and painful for me, but also I was embarrassed about it. And I think what I have worked on the last decade is not being embarrassed about illness, about sort of the feelings, the emotions. Like I am an aging woman, like we all are aging, and I have symptoms too. And I think that it's so important to take away the stigma that I'm getting older and things don't aren't as perky as they used to be, and things are saggier, and for me as well, just like every single person. And you work on your health, you do the best you can. If you need a hormone or hormone replacement because you're just miserable, talk to your doctors about it, but also think about those supplement options. And some people will have benefit and some people won't. You find what works for you, but there's usually no harm to many of them, like magnesium, black cohosh, flax seeds. But eating more sort of plant-based, losing weight, being active, these are keys to success. But don't start them willy-nilly. Make sure that we have a good menopause trained gynecologist, a menopause trained or educated cardiologist if you have heart conditions. And I think with that, you can make a good educated decision. Dr. Lundberg, Gina, it's been fantastic to have you on the show. Thank you so much for your time, your expertise, and what you do for women in general, but also women in cardiology. I certainly went through a lot of what you went through, being the only woman, being told that the only women cardiologists people knew were alcoholics or got divorces. Well, okay, that was great to hear when I was just out of fellowship that was my future. And so this is what we have to deal with. And so I appreciate you being such an advocate and such a pioneer in this space. So thank you so much.
Well, thank you, Monica. And I appreciate all you're doing to bring plant-based food as medicine to the forefront, because I'm totally with you there. I'm a big believer.
I love it. Thank you so much. And everybody, the information on Dr. Lundberg's in the show notes. If you want to get a consult with her, you're going to have to go to Atlanta because that's where she lives. Okay. Thank you so much.